Good morning, everyone. My name is Sharon Lawrence, and I have another presentation regarding hernias. So without further ado, I'll get started. So I am a board-certified general surgeon. I am certified in robotic surgery as well. I practice in northern New Jersey. I have an office in North Arlington, New Jersey, and I operate at Hudson Regional Hospital in Secaucus. So just so you're aware, I'm going to talk about hernias and how I'd manage them. This is not medical advice. This is general information. If you have a hernia and you need evaluation, you must see your doctor. You cannot take this as your medical advice on what to do. So, what is a hernia? So, a hernia is a weakness in the strength layers of either the abdomen or the groin, your belly or your groin. Um, the weakness can be due to, can be naturally occurring areas where you have openings in the strength layer to allow structures to go through, such as at your belly button. That's has a natural opening that is there at development that allows your umbilical cord to go through. Or in the groin, you have natural openings there that allow, and particularly in men, it allows structures to go down towards the testicles that contain blood vessels and your vas deferens, which carries sperm and other, just important for reproduction. Um, you can also have a weakness due to past surgeries. That would be an incisional hernia. If you had an incision made and it healed, but maybe it's weaker in that area, maybe it didn't heal well, maybe it's just stretched out and developed a hole or an opening, that would be a hernia as well. A peristomal hernia is also something similarly related to surgery. Basically, when you have an ostomy or your intestine is brought up to your abdominal wall, um, sometimes you can have part of the intestine poke through adjacent to um, that connection to the abdominal wall. That's a peristomal hernia. Um, things that cause increased pressure in your belly will lead to increased risk of hernia development. Or worsening of your hernia if you have one. So things that can increase that pressure include heavy lifting, um, being obese, excessive coughing. So sometimes people who might have COPD or smoke, they might develop a lot of coughing and have worsening of their hernias. Or constipation. If you have chronic constipation, you're constantly bearing down to try to push stool out, then that can also push on your hernias, and you might feel. Sometimes people say they had a large bowel movement and felt movement in their hernia as well, and that's because you're pushing down and pushing things towards the hernia. So there are multiple types of hernias. The concept of the hernia is as described as a weakness or a hole in the strength layer, but where it's located will determine the name. A ventral hernia is basically in the midline or middle of your abdomen. Um, these can also be called epigastric hernias if they're in the upper portion of the abdomen. Um, an umbilical hernia is a belly button hernia, and that's lower down, but it's still a ventral hernia type of ventral hernia. It's smaller and can be repaired sometimes with um, a smaller mesh, smaller surgery. Diastasis recti is not a hernia, but it's something that is sometimes repaired with ventral hernias. It's basically the strength layer that is between your two abdominal muscles. When someone has a six pack and there's like that line in the middle of your six pack, the lines that create the pack. That's fascia, that's strength tissue. That's the strength layer, is strength tissue. If it's stretched out, now those muscles, instead of being close to one another, will be separated. That's a diastasis recti, and that can be um, fixed during a hernia repair. An incisional hernia, as mentioned, occurs at the site of a prior surgery. An inguinal hernia is a groin hernia. It's very common, particularly in men, and it's occurs at the site of one of the holes, as mentioned, where um, vessels and other reproductive structures travel from your abdomen down and pelvis down into the groin. A femoral hernia is also a groin hernia. It's less common. It occurs near the same hole or weakness as the inguinal hernia, but a little bit lower. Basically, a hole or opening where the femoral, like the large blood vessels, are exiting from the pelvis down into the groin. That's where the femoral hernia would occur. Since this is a smaller space and tighter, oftentimes when one of these develops, it's an emergency and you might need to have an emergency surgery. A Spigelian hernia is a type of abdominal hernia. It's not in the midline, not in the center of your belly, but more to the side, lower below the level of the belly button. It's basically a place with a natural thinning out of the strength layer. Um, I won't get into the anatomy too much, but basically the strength layer at this specific site gets thinner, and so you have a risk for developing hernia. Now, there's also a hiatal hernia or a diaphragm hernia. This basically is a hernia within the muscle layer that separates the abdomen or belly from the chest. That usually is along the side of the esophagus, where basically the food pipe is going down into the belly. Sometimes it's just that the esophagus slides up and down. Sometimes organs go up there with it. Sometimes you have no symptoms, and sometimes you have gastric acid reflux, pain with eating, difficulty swallowing, and so forth. And then the peristomal hernia, as mentioned before, that's a hernia that develops next to an ostomy. So most hernias, purely ventral hernias, incisional hernias, inguinal, femoral, Spigelian, and peristomal, these present with a bulge in the area of concern, right? So if you have a belly button hernia, you'll see a bulge at your belly button. It usually gets bigger or shows up when you bear down, or if you lift something heavy, if you're bearing down like you're having a bowel movement, then you'll see it kind of get larger. Sometimes they can be painful. It can be chronically painful, or it can just kind of come out of nowhere, feel painful, and be bigger. It can start out small and get bigger over time. Sometimes the skin over it can change in appearance, particularly if it's been there for a long time and it's very large. If the skin looked normal and then all of a sudden it got bigger, got painful, and the skin changed quickly, that's all signs of an emergency. So basically, this next line, these are usually reducible. You can push them back in. If they can no longer be pushed back in and you see changes overlying it and pain, then that's a sign of emergency. Also, if you have nausea or vomiting with the appearance of the hernia, that can also be a sign of an emergency, because sometimes your intestine goes into the opening to the hernia and gets stuck there. And that causes a blockage of your intestine, and then also can reduce the blood flow to your intestine. So that's something to keep in mind. So you have a hernia, you should bring this up to your primary doctor first. They'll most likely refer you to a surgeon. A physical exam will be performed. They'll to assess the size of the hernia to see if it's reducible, can be pushed back in, if it hurts when you press on it, if you have skin changes on top. Sometimes, no imaging is really needed if it's pretty small and you can feel the extent of the opening of the defect or hole in the fascia. If you can't feel it, if it's not obvious, or if it's really large and you kind of want to see what you're dealing with, then sometimes you'll get a CT scan. It allows us to see how big this opening is, what's inside the hernia, and plan for repair. So if you have a small belly button hernia, you might not get imaging for that. Groin hernias can sometimes be evaluated with ultrasound. So you might not get an ultrasound, a CAT scan, you might get an ultrasound. If the hernia is stuck, as mentioned before, that means it cannot be reduced, cannot be pushed back in. It's painful, there's skin changes, you're vomiting. Then, again, go to the emergency room. You might have a stuck hernia. So as you can see here, I have a picture of a reducible one. It has you see that circle, that's the hole that in the strength layer that allowed the intestine, that loop, to go through, and it's wider there than in the other pictures. Reducible hernias usually have a larger opening, so things can kind of slip in and slip out very easily. You can have what's called an incarcerated or not reducible hernia. That's when we start to get concerned. But not every hernia that's incarcerated or stuck is an emergency. You won't can't really know. Sometimes it's just been like that forever. You can't really know until you get evaluated by the doctor for to rule out or rule in a problem. And then strangulated, as you can see, that has a very tight opening. Intestine is stuck there. It's changed color because it doesn't have good blood supply. That intestine can lose blood supply and die. So this is an emergency. You need to get that intestine released so that you can try to save it. If it's too late and it's really been damaged, then that might have to be cut away, and then the hernia closed. And oftentimes it's that then affects your ability to properly repair the hernia. So the sooner you notice a hernia, the better it is to, as soon as you notice a hernia, it's best to get it evaluated. Now, as I mentioned several times, if you have a stuck hernia, go to the emergency room. If it's not stuck, then it's a reducible hernia. Um, if they're asymptomatic, then your doctor might choose to leave it alone. And things that will, push someone to not operate would be, maybe you have other medical problems that are more concerning that need to be addressed first. Maybe you're just not a good person to have surgery because, you don't do well with general anesthesia. Maybe there's concern that your heart is not strong enough to have surgery. So if you're not having symptoms, they'll say, you know what, just leave it be. Keep an eye on it. If it becomes an emergency, then we'll deal with it. If not, then, we don't want to harm you during, an operation. Um, Other times that you might put off treatments, but still hope to fix it is if there are risk factors that would increase the risk of the hernia coming back. So something like having being obese or smoking. Those are two things that increase the risk of your hernia coming back after it's been repaired. So if there are no symptoms or the symptoms are mild, oftentimes you'll be told, you should first try to lose some weight, stop smoking before we go through extensive repair of a hernia. So hernia surgery, it can be done in a minimally invasive way or in an open way with a large incision. That will be determined based on the size of your hernia, how long it's been there, what is involved. Like, is it are there a lot of organs that are going through it, and how many other surgeries you've had in the past. And the surgeon will evaluate your history, evaluate your hernia, and then kind of come to a decision with you about that. To fix either way, if you have a minimally invasive repair or an open repair, the first step is to clear away the strength layer and then close the hole. And this sounds very simple, but depending on again what's in the hernia, what's going through the hernia, what scar tissue you may have, um, whether how many other surgeries you've had, all these things affect how long this takes, how extensive of a surgery is needed. Once it's been cleared away and the hole is closed, a mesh is placed, which is basically a thin sheet of a material that's synthetic, um, or like a thin sheet of a thin material that goes along the strength layer, is sutured up to it, and over time that doesn't go away. The strength layer and the mesh kind of fuse together as it heals, and this allows for a stronger strength layer. And this is important because usually if you have a hernia, that strength layer or fascia, I call the strength layer just for simplicity, but it's fascia. That fascia is weakened and thin. And so just simply closing it by suturing it can lead to it tearing down the line. So you add the mesh, it helps to reinforce it and it reduces the risk of recurrence. If it's a minimally invasive surgery, then it's most likely going to be a same-day surgery. Sometimes you might stay overnight. If it's an open surgery, if it's a really big hernia, then that's different. You might be there longer. If you come into the emergency room and have an emergency need, then you might be there longer in the hospital. After the surgery is done, you're usually placed an abdominal binder to help give some support, structural support, as you heal. And you're given pain medication. Some patients, really, don't have too much pain, but I do find a lot of patients will have pain. I like to give a short course of narcotic medication to help with that pain, and then wean down to Tylenol, Motrin, over-the-counter medications. Over time, patients will also say they feel little twinges of pain, which is usually as the mesh and the fascia or strength layer is healing together and incorporating together. That can lead to little twinges or faint feelings of pain over time. After the surgery, it's important that you avoid heavy lifting for several weeks to allow full healing and incorporation of the mesh, um, and reduce the risk of recurrence. So if you have any questions about the different types of hernias that exist and about your own hernia and how it can be treated, you can leave questions in the comments. And I can't, again, give medical advice, but I can give general information about hernias and, about different symptoms and so forth. If you would like to be seen for an evaluation, you can reach out to me via email or call the number below on the screen or visit my website in order to schedule a consultation. I look forward to hearing from you.